La musica. Non c'è la musica. Dear friends and colleagues, it is with a really great pleasure that we resume the organization of webinars which have been so successful in the past year. First of all, welcome to all participants. This year's topic is focused on hemodynamics, and the organization of the modules will be handled, as always, by UENPS and IPOKRaTES. But I am very pleased to underline that from this year, we will also benefit from the collaboration of the European Association of Perinatal Medicine. So now I leave the floor to Professor Stockdad. He is the chairman of UENPS Scientific Board, to Professor Noy, President of IPOKRaTES, and Professor Iris De Campos, President of EAPM. I want also thanks to the speaker, Professor Andrew Weeks, for his participation. And I remind you that all webinars will be available on the UENPS website. Dear Hola, please keep the floor. Thank you.
Yeah, thank you very much, Corrado, and welcome to all of you to this webinar, this first model. It's a great pleasure to be together with all of you. I think there are more than 1,000 registered for this webinar. So it's my pleasure to introduce the chairperson of today, Professor Diego Eres de Campos. He's Professor of Obstetrics and Gynecology in Lisbon, but he's also the President of European Association of Perinatal Medicine. So I leave the floor to you, Diego, but I want to remind all the participants that you can submit your questions to the Q&A box. You see that you have the Q&A box at the bottom of the screen. So please don't, please send in your questions and we'll try to get them answered. I also welcome Ola Andersson from Sweden, who will speak to us on Thursday. So please, Diego.
Thank you very much, Ola. It's a great pleasure to be here with all of you, particularly because this is the first webinar that we do together, UNPS and the EAPM, the European Association of Perinatal Medicine. It's great to be doing these webinars together, and I hope it will be the first of many initiatives in the future. It's a great pleasure for me to introduce our first speaker today, who is Professor Andrew Weeks. Thank you very much for accepting our invitation, Andrew. Andrew Weeks is Professor of International Maternal Healthcare at the University of Liverpool and is the Director of the SANU Research Unit. And in 2001, he spent 2 years as a visiting lecturer in obstetrics and gynecology at the Makerere University in Uganda. He returned in 2003, where he joined the University of Liverpool in the UK and was appointed later professor in 2011. He's also an honorary consultant obstetrician at the Liverpool Women's Hospital, whom I'm sure many of you will know as one of the leading university hospitals in the UK. His primary interest is in the translation of maternity care from high to low resource settings. And he has a particular interest in misoprostol and postpartum hemorrhage, management of labor, and management of the third stage of labor. He has more than 250 publications in his name, and currently he runs several multi-center clinical trials, both in the UK, in Uganda, and in India. So once again, thank you very much, Andrew, for this for joining us. And we're going to hear about clamping of the umbilical cord and placental transfusion. Over to you, Andrew.
Well, thank you very much for your kind welcome, and thank you as well for the invitation to speak to you this afternoon. Welcome to all of you who are joining from wherever you are across Europe or across from anywhere in the world. Now, there's a series of talks that are being given in the webinars over the next couple of days about management of the cord at the time of birth. And I'm unashamedly giving the obstetrician's view. So I want to speak today maybe about the way that I see it, particularly as an obstetrician. And so I want to take you through not only why immediate cord clamping was brought in, because I'm afraid it was probably us who did that. It was our fault to start with that we introduced immediate cord clamping many years back. But then also take through what is the evidence from our side, from the postpartum hemorrhage, from the maternal side. And then I'll look at ways in which we've tried to improve care over the last few years. I'm hoping to speak for maybe 40 minutes and then give some time for questions at the end. So why do we do immediate cord clamping? Well, it comes down really to this problem of maternal deaths. And here's the maternal deaths going back. This is going back to 1850, so very long time ago. And you can see how these are deaths from hemorrhage. They were slowly decreasing, and then suddenly they started this very rapid decrease around the time of major industrialization and the time of the National Health Service. Now, if you look at the uterotonics that were developed or which became available, ergometrin maybe around 1935, blood transfusion was a major cause of reduction in maternal deaths. In fact, oxytocin only came around 1954, and the active management of the third stage of labor, which brings in the cord clamping issue, only really came in the 60s. So it wasn't really active management. There was a time at which we said everybody must have active management, which is everyone must have then immediate cord clamping back in the 80s after the Bristol trial. But actually, it wasn't really the major cause in the UK of a reduction in maternal deaths. And so it comes down then to PPH prophylaxis. Once we had a good quality oxytocin, this is 1962, this is one of the very early papers in the British Medical Journal. It came down to saying, well, let's give a uterotonic to everyone as prophylaxis. But because we were giving oxytocin and it wasn't really clear how much crossed the placenta and how quickly, people wanted to protect the neonate. And therefore, the thought was that not only should you give the oxytocic at the time of the birth of the anterior shoulder, so spoken, but you should also do immediate cord clamping at that moment so that none of it got through into the fetus, but then also do controlled cord traction on the cord so as to prevent the placenta getting stuck and getting trapped in the uterus. And so came what was almost it was like a mantra. Everyone, when I first started training in the early 90s, they would say, you must do active management. We're going to prevent all these maternal deaths if only we did active management. And it was really very dangerous to question it. Nobody would question it. And yet there were the three components of it. There was the uterotonic, there was the immediate cord clamping, and there was a controlled cord traction. And nobody really separated out the three. The immediate cord clamping was sort of done at the time because we thought the cord was just a piece of string which connected the baby to the placenta, wasn't really needed, so you might as well cut it at that point to facilitate the management of the third stage. But of course, since then, we've come to know a lot of, there's been a lot of progress made in terms of clinical trials. And of course, the best evidence comes from the systematic reviews, and there's now systematic reviews of all of these different components. So if we take, first of all, the uterotonic, it's very clear, irrespective of what you do about controlled cord traction or what you do about cord clamping, if you give the uterotonic, then you reduce the risk of postpartum hemorrhage. And really, it's proven to be really that it's the uterotonic which is doing the effect. And so if you look at one of the Cochrane reviews, this is now 2019, if you give prophylactic, this is oxytocin alone, and I know that many of you will give maybe ergometrin or oxytocin plus ergometrin, but if you give oxytocin alone, which fits with FIGO WHO guidelines, then you not only reduce the risk of the maternal blood loss at 500 mils, also reduce it at 1,000 mils, and reduce need for additional uterotonics. There is of course, you're getting into smaller numbers here, and the smaller reduction in blood transfusion, so is not a statistically significant result. So it's clear that with the uterotonic, that's the main element. That's what's needed. What about controlled cord traction? Well, I don't know if this is what your labour ward looks like sometimes with people trying to deliver the placenta, but there was a big question of, do you need to do controlled cord traction? Because and the World Health Organization in around 2008 was particularly interested in this, because they were concerned as to what skills does an accoucheur or a midwife require. So they set about doing a huge randomized trials, the sort which really only WHO managed to do, and they published this in the Lancet 2012. And you can see here they had nearly 25,000 women in a huge multi-center study. They all had oxytocin. They all had clamping at 1 to 3 minutes. By this stage, we realized that there was benefit in delayed cord clamping, but they were randomized to either controlled cord traction immediately after the first contraction, or maternal effort only, and you just left it to the mother. You didn't pull on the cord at all, you just left it to expel itself. And their primary outcome was measured postpartum hemorrhage. So I ask you, what do you think would be the effect? You might expect there to be increases in postpartum hemorrhage, maybe if you just left the placenta, you haven't even touched the placenta. If you just leave it there, what would happen? You'd get retained placenta, you get PPH. What actually was the results? Actually, no difference in postpartum hemorrhage at all. And if you look at the numbers with whether you define postpartum hemorrhage as over 1,000 mils or over 500 mils, it really didn't make much difference. Very little, if any, difference between the two. What's interesting was that there were a few women who had retained placentas. And there was one of the sites, they had multiple sites, but one of the big sites was in the Philippines. And in the Philippines, every site used oxytocin alone, except for the Philippines, where they continued with oxytocin and ergometrin. Now, in the UK, we call that syntometrin. I think it's called different things around the world, but it contains 5 units of oxytocin and 500 micrograms of ergometrin given intramuscularly. And in those sites, there was a big increase in retained placenta in those who delivered just with maternal effort. So it looks as if controlled cord traction beneficial in those when you're using ergometrin, but not if you're using oxytocin alone. So what do we find then? That in terms of active management of the 3rd stage of labour, it's the uterotonic, which is the critical thing. Controlled cord traction is helpful and maybe useful if you're using ergometrin for prophylaxis. But if you're doing like most places recommend, just giving oxytocin alone and reserving ergometrin, which of course causes high blood pressure and vomiting, and you're reserving those for just those who bleed, then there's no need for the controlled cord traction. And what about the subject of these very talks, the timing of cord clamping? Does that change the amount of postpartum hemorrhage? Well, of course, most of the work on cord clamping and the timing of it is done by neonatologists. So very many of them have actually just skipped over the postpartum hemorrhage bit completely. Not really. Should it have an effect? Probably not. But it's often forgotten about because of the emphasis on the baby. But Ola Andersson, who's here, has done one of the best studies on this. It's only 382 term babies. But there, I think maybe people know this study already, immediate cord clamping versus 3 minutes. But what was interesting was that they looked very specifically at the blood loss. Now, they weighed the swabs, they looked at any collected blood up to 2 hours in length of time. And you can see here at the bottom, really no difference in the postpartum hemorrhage. There we go, greater than 500 mils, no difference between the two. Severe postpartum hemorrhage, I guess you might say there's some kind of signal there of a reduction, but really not of any great volume at all. There may be some benefit to delaying cord clamping. And if you look at the length of 3rd stage, none of this really statistically significant. These are small numbers. But there may be a slight reduction in the retained placenta rate. And interestingly, that does fit with some other studies, because some other studies have looked at whether placental drainage is beneficial in preventing retained placenta. They're very small, there's really not much information in them, but they also suggest you may get some benefit in a reduction in retained placentas by, once you've cut and clamped the cord, opening the cord and letting the blood from the placenta just fall away or be collected. Now, of course, that's really no difference to just letting it go across into the baby. Yeah, so it may have a slight benefit, but not huge amounts. What about preterm births? I think they'll come to this more in the next few days. These are the famous Lancet systematic review, which was published only at the end of last year. So this is now in November of last year. They did a very large systematic review and an individual participant data meta-analysis. And you actually have to search a long way to try and find the data on postpartum hemorrhage. No, nobody's really interested. It's all moved on to the baby effect. But if you look, here we go, Appendix L, this is page 430 of the appendix. You can find, here we go, right down in the bottom corner, immediate cord clamping versus delayed cord clamping, postpartum hemorrhage. 9 studies looked at the amount of postpartum hemorrhage with 850 women, and you can see no effect there, which actually is what we'd expect. We wouldn't expect a huge amount of difference. But it does tell us then, right, actually the active management of the 3rd stage of labour is about the uterotonic. From the mother's point of view, we really don't need to worry about the timing of cord clamping. We don't need to worry that we're damaging the mother herself through delaying of cord clamping. In fact, if anything, there may be a slight improvement in the rate of retained placenta. Now, all the talk so far that I've spoken about really has been about vaginal births. We're really I appreciate some of these systematic reviews have got cesarean sections in them, but what about cesarean section? And it's strange that the management of the third stage, from the obstetrician point of view, is really far less studied in cesarean section. But there's a lot of evidence about how you should manage the third stage at the cesarean section. And the one thing that is clear from, look at this, this is the Cochrane systematic review. This is even going back to 2008, and the study's been done since. This is 13 different studies saying at the time of cesarean section, should the obstetrician take their hand and scoop out the placenta at the time of just after the cesarean section, or should you leave it alone? Or should you just wait for the placenta to come on its own? And actually the evidence is very clear. If you do a manual removal, and of course you need to do that fairly quickly, you need to do that within maybe 1 or 2 minutes because the placenta will come out on its own very quickly. If you do a manual removal, you get more infection, you get more endometritis, you get more blood loss. This is 100 mils on average. This is the weighed mean difference. You get more blood loss, you get more people who bleed heavily. So over 1,000 mils, the relative risk is 1.8. So you get a longer hospital stay because of this endometritis. So it's common practice in many places in the world that you do a cesarean section, you cut the baby, get the baby out, scoop your hand, scoop the placenta out. Actually, that's not good practice. And I think that it's been well shown that we shouldn't be doing that. Our own NICE guidelines were updated last year, 2021, and they redid all this systematic review, and they again concluded, please don't put your hand in to scoop the placenta out unless you really need to. And there's clearly some retained placentas which are adherent, but don't do it unless you need to. And actually that's very convenient from the cesarean section, from the cord clamping point of view, because I don't think that the neonatologists either want us to be scooping out the placenta. It's far better just to leave it and wait, and on the whole it just comes out on its own. I'll show you a video in a minute, and I'll talk you through certainly what my practice is, which I appreciate may not be the perfect practice, but it'll give us a point for discussion. So what do we do in Liverpool? Well, in Liverpool, I think we were fairly early on to the cord clamping work. So we've had a mandatory 2-minute delay for cord clamping since 2012. We were fortunate, I guess, that I had an interest in it. Bill Yoxall, who was the lead neonatologist, also had an interest in it. And so did Simon Megan, who was the head of midwifery at the time, and getting these 3 groups together, the midwifery group plus the obstetricians plus the neonatologist, meant that actually it was very easy to do. We put together guidelines and it was implemented really very quickly. And what a lot of the midwives said when we first said you need to leave it for 2 minutes, they said, actually, we've been doing that already. We've never believed that you should do immediate cord clamping. So as when the babies came out at term and they were comfortable and happy, I know we were supposed to do immediate, but we fiddled around and we dried the baby and we comforted and we did skin to skin first. And only after that time did we actually cut and clamp the cord. So they were very happy with it. It was more difficult for deliveries with forceps or ventouse, and it was more difficult with cesarean section. And I'll explain that in a minute. But in fact, at caesarean section, it very rapidly became accepted. We have in our guidelines this picture here, which, because there was a question at the time of where should you put the baby? There was a worry that if you delivered the baby vaginally, and then the mother, who in our tradition in the UK usually sit up. I know some do in all fours. Many women will deliver in different positions, but our tradition has largely been a semi-recumbent sitting position. And if so, where can you put the baby? Where is too high? And the studies going back many years now into the 80s demonstrated that actually up to 20 centimeters was fine. Now, if you look at 20 centimeters and you've got a baby which has just come from the uterus and the placenta is within the uterus, if the baby sits on top of the uterus on the mother or on the mother's chest, it's nowhere near that 20 centimeter mark. And at 20 centimeter, you seem to get all the benefits. Actually, there was a follow-up randomized trial later on to look at actually if you resuscitate, if you bring the baby as soon as it's born onto the maternal abdomen, do you still get the benefits of delayed cord clamping in terms of the hematological changes? And yes, you get all those. One of the questions that came up, though, was, okay, we're going to do standard 2 minutes for everybody, and this has now been 12 years we've been doing this. When should you not do it? Are there times at which we get anxious? And now these are our current guidelines, which actually we very rarely use. I had to look them up because we've now got the facilities for bedside resuscitation, which I'll talk about in a minute. But it means that if we've got babies who are born, who are premature babies, we bring them straight onto the Life Start trolley, and that sort of sorts out the problem. But the question is, if you don't have the facilities for bedside resuscitation, or you can't resuscitate the baby with the cord intact, at what point should you cut and clamp the cord and take the baby across to the resuscitator? And our neonatologists in Liverpool chose these criteria: an apneic baby with significant fresh meconium or known profound asphyxia prior to birth. Now, known profound asphyxia, these are our profound bradycardias who are rushing through to theatre for birth, and you haven't had time to get the bedside resuscitation equipment set up. Now, I'd be interested to know what some of the neonatologists amongst you think about this. For a baby who is not establishing normally respiratory efforts and there's no resuscitation, at what point? Well, what we've put here is to clamp the cords at 30 seconds. Now, this relates to a range. You can imagine there was discussion amongst my colleagues. I was pushing for much later and saying, well, you should at least leave it a minute. And I think we've seen from some of Ola's work that a minute is perfectly all right. But then other people were saying, no, you should just cut and clamp the cord. So we came to a compromise at 30 seconds. Babies with any other specific problems, team discussions. And I think that things like intrauterine growth restriction have been discussed, but in fact, the question was, would they have higher hemoglobin levels from chronic hypoxia? In truth, we delay cord clamping exactly the same with intrauterine growth restriction. I think that argument has largely gone away. Monochorionic twins, we do delayed cord clamping with both sets of twins. I'll show you a video in a minute. Maternal viral infection. There was a talk in the middle of HIV. Well, what if you had an HIV infected baby? Surely you don't want the blood to come across. The blood might have HIV in it, and therefore, and actually we killed that argument by saying, well, okay, we'll let the blood come across and then just drain away a quarter of the baby's blood day 2. Maybe that would be the better way, because at least then the baby will have stabilized by that point. That would be a safer way if you want to get rid of that HIV, any HIV in the blood. And they didn't like that idea at all. So in fact, Of course, the same blood has been passing for the last 9 months between the placenta and the baby. So why it should suddenly change at the time of birth, we don't know. So we, in fact, have I can't remember the last time I did an immediate cord clamping on a neonate of any gestation in Liverpool. But that brings me to the problem, though, of what we do about very premature babies, because there is what I would call the cord clamping paradox, and that's the paradox is that the baby in whom delayed cord clamping is easy is actually those babies who come out screaming, they're term babies, and everyone says, oh, well, delayed cord clamping, well, yeah, they'll get a little bit of benefit from it, but they're not really the ones who will greatly benefit. In truth, the more complex it is to defer cord clamping, the more benefit there is to the baby. And it's probably the earlier gestations, once you get to those 25 weekers, those are the ones who are going to really benefit, and yet they're the ones who are really difficult to delay the cord clamping in. So how do we deal with that paradox? Because there's a number of barriers that we faced going back to 2012 when we were looking at this. Firstly, we were unable to resuscitate the baby close to the mother. We talked about belly resuscitation, actually resuscitating on the belly. Can you try and do that? But actually getting the positioning of the head is just too difficult. From my point of view, actually, I don't want to be resuscitating a 25-week baby at all. I want the pediatrician there as quickly as possible. And there was also anxieties about them resuscitating the baby right alongside the mother. So there were a number of factors which made us anxious. Now, my neonatal colleagues say, look, Andrew, it's no problem. You just resuscitate 25 weekers. It's fine. It's easy to do. But as an obstetrician, of course, it's very good that we have a perinatal medicine societies, but actually we've traditionally been apart. And there's sort of slightly different characteristics, and in the same way that many neonatologists would be very uncomfortable. A litres blood loss, that's not a problem. Going into the vagina, let's do some stitches. A lot of my neonatal colleagues go, oh, I think I'll stick with my neonatal babies, thank you, and with my 2 mils and 3 mils of blood loss. So when I try and explain, it's sometimes difficult to explain to my colleagues in the neonatologists. But there's a good, there's something which maybe will help illustrate what I'm talking about. Does anyone here watch American football? I appreciate it's not so common in Europe, and it's not a huge favorite of mine, but I think it illustrates the point very well. So these people with the black tops on, these are the offensive team, and you can see this person in the center here has got the ball in the center there, and he's going to pass it back to the quarterback. Now, this ball is about 500 grams, and it is covered in skin, interestingly. And now, as an obstetrician standing here, if I see something 500 grams appearing from between somebody's legs, then I assume that it's a baby. And that's very similar to this situation. And as soon as I get the ball here, if I get this 500-grammed precious thing, I want to pass it straight on as quickly as I can to the pediatricians. Now, here are the pediatricians on the outside, and they're desperate to get to the neonatal unit because that's their comfort space. But we've got to achieve that. We've got to somehow get the transfer of this precious thing out to the pediatricians. So let's see what happens. First of all, the player flicks it between their legs. Okay. And here I am as obstetrician thinking, oh, shit, 500-gram baby, get it to the pediatricians as quickly as possible. And what scares me actually is not only that neonatal resuscitation isn't my skill, but it's also that there's these people here who are the lawyers who are coming to try and get me. And they know that these babies at 25 weeks has got a high risk of cerebral palsy. And if I'm sitting and I haven't done my most recent training, I'm holding on to this 25-weeker and this baby ends up in problems, it's going to be me who's in trouble. So I try and get rid of it. And what happens if I hold on too long? I'm afraid we get into problems and I get crushed by the lawyers. And of course, the lawyers are triumphant, they're delighted. And the baby is left at the side here. So, sorry, that's maybe a little bit of a flippant comparison, but I think it illustrates some of the anxieties that as midwives and neonatologists we have about holding a baby and looking after a baby in those critical moments just after birth, especially if it's going to be 2-3 minutes. So, how are we going to resolve this? Well, back in 2010, a group of us set about trying to develop a kit for bedside resuscitation. And I just want to spend the rest of my few minutes now talking about how that progressed. So there was a team of us with some fantastic enthusiasts amongst us. So David Hutchin had done a lot of work on driving this forward. Bill Yoxall was the neonatal lead in Liverpool. Lilia Dooley had got the funding together. Peter Watt was the designer who I've worked with over many years, who did a lot of the designs. And when we first met together in 2010 to say, well, how are we going to solve this? We came up with these original designs here, which was really just on a scrap of paper, as how you may be able to get something which looks like one of those breakfast tables that if you sit in bed and you eat your food, the idea was that the wheels would go under the bed, and then you've got a resuscitation platform on the top, which you can push forward or pull back, and you can adjust it in its height, and it's got suction and oxygen and air there. And actually the design hasn't, these were created in the train on the way home back in 2010 from our meeting, and the design hasn't changed greatly. You can see much smarter designs here. I think these are ones which Peter Watt did, and you can see how we started looking at, well, how would it work at cesarean section? How would it work at a vaginal birth or preterm vaginal birth? And you can see then how over time. This was an original, this is Anne-Marie Huken, who did a trial of cord clamping back in 2006, and she had done exactly the same thing. What she'd taken was an overbed table and just put a cushion on top of it. And so you can see how ours really is just a spin-off of that. And then we actually set about trying to make a model. And it was really when Inditherm came along and we started a collaboration with Nick Bettles and Inditherm in 2012 that they commercialized it and made it into a much better model. Now, if you want to read about the design of it, it's all published in BMJ Innovations. But we then set about saying, well, actually, what about our fears? Does it work? How do you make it work? And we did an initial evaluation. This is published 2014, so this is work done in 2013. And what we wanted to see was not only could it be used, but also what were the views of, this was the clinicians' views about, well, what do the clinicians think about this? Did they think all this was crazy? And when we evaluated the clinicians, this is on 70 babies, how good was access? So if it was in this light color here, this was worse, blue is the same, or orange is better or much better. You can see how access to the baby was much better with the Life Start trolley. Assessing the baby was about the same, didn't really make any difference. Access to equipment, a little bit worse. There isn't the same equipment placed, but most people just said, oh, it's the same. Providing interventions, exactly the same. People weren't bothered. What was strange was that the communication was much easier, and you can see how it's the one thing where people said communication with patients, with the parents, much better. And our fear that we had was that we might be resuscitating a baby right alongside the mother, and that we thought, that's not fair on the mother to do that, that we should protect the mother. And of course, what we found out that it wasn't about protecting the mother. It was actually about making sure that the communication was much improved by this, because you could explain exactly what you were doing. It was actually the clinicians who were more anxious about this, and it was the junior neonatologists who were just starting out or in training. Resuscitating a neonate right beside the mother is a scary thing to do, but for the more experienced ones, actually it improved things a lot. But what about the parents? What did they think of that? Well, we did 11 in-depth interviews with parents, and actually they were delighted with it. So to our surprise, so this is a mother with a preterm baby after a vaginal birth. So it's nice having her just that bit closer to her and be able to hold her hand and get a bit of normality out of birth. It's not all traumatizing. There's that little teeny bit of goodness to have her there and to see her. And their experience has otherwise been that the baby goes rushed off to neonatal unit. It goes to the side of the room and then the baby's gone, and they really don't have any connection with the baby. Here's a baby born by cesarean section. It was really nice that he could be there and I could still see him instead of taking him away right there. Another baby at term, had they taken away, yes, I think I would have probably got a bit more distressed, because it's like, why are you taking her over there? What's wrong? So in fact, the qualitative work we did was very reassuring. And this is my labour ward today, and you can see we've got 6 of these Life Start trolleys, which we line up in the corridor. There's one in the theatres, and they're ready at any point to rush into the rooms, because often it's things like shoulder dystocias where they're particularly beneficial. I just want to show you through, we've got a bit of video here of cesarean section on the Life Start trolley. So here am I on the delivering. These are actually twins. These are 30-week twins. Now, there's a number of things to notice here. First of all is that we've brought the Life Start in, and it's covered in a drape, a sterile drape. The person who's resuscitating is actually one of our advanced neonatal practitioners. And you see here, actually, she's not wearing sterile gloves. She's wearing, from the practicalities point of view, she's wearing clean gloves, but not sterile gloves, because she's a little bit away from the field. And here's my assistant here, who just steps slightly to one side while we're waiting. Now, this baby's actually got quite a long cord, as you'll see as we move forward. It's a reasonably long cord, but in fact, we could bring in the trolley far closer if we wanted to. The other thing to notice is that we've given the oxytocin already of course we haven't in this twin birth, but in a singleton birth we would have given the oxytocin at the normal time. And what I'm particularly interested in here is in the wound edges of the uterus, because here I want to get my green armitage clamps on fairly quickly. There's often bleeders around, and as you cut into it, there's often bleeders. And so no problem with putting on atraumatic clamps onto the bleeders while you're waiting for these 2 minutes. Now you can see this is just a minute in. They're continuing to care for the baby here. You can see how actually the cord, most of the blood has emptied out of the cord. And you could say to me, well, actually, aren't you better saying wait for white, wait until the cord turns white? And it's true that probably is better way of running it. But actually the 2 minutes makes it far easier. People are far happier with a set 2 minute period. And so we leave it for the 2 minutes, and we all do a 2 minute period. The other thing that I would point out here, we've actually got a screen. Now, I don't know if you can see it, there's a screen up between the mother and us, and we don't use that anymore. This is back in 2012, and in fact, we've taken the screen down now so the mother can watch the resuscitation here. The final thing to show is that here we've got to the 2 minutes, she's clamped and she's going to cut the cord. And what they're going to do is transfer the baby then. They're just going to reverse out of the situation. There they go. They've kept the baby warm. Of course, with more premature babies, they'll put it in a bag. But at this stage, they've transferred it. They're going to transfer it across onto our room-side resuscitation, because that's what they're more used to. So they use the LifeStart trolley for collecting the baby, as it were, and allowing that care of the baby just at the time of birth before they reverse out. One thing to say is that we did have trouble early on, when we first implemented it, it went extremely well. And then actually levels of delayed cord clamping dropped off, especially in the premature. So we did a quality improvement project back in 2018, 2019 to improve it. And you can see how with increased knowledge, we're getting up our 2-minute cord clamping rate. And we're now up at 100%, and we've kept it about that. Now, of course, LifeStart isn't the only one in town. There's various other options. I think this is one's called Inspire in Canada. This is a Nuna table in the US. People will have heard of the Concord from the Netherlands. And so there are other options for it. And we're very pleased that this has opened up the space. And just to finish off, I'm aware of the time, but just to finish off, we have set up also some work in Uganda, because in Uganda, actually, it's probably even more important that you've got an ability to resuscitate at the bedside with an intact cord. Anemia is far more of a problem. And actually, if you've only got one midwife who's delivering a baby, the last thing you want to do is for the midwife to leave the baby, to go away with the baby for the 3rd stage of labor. So we set about trying to make a much simpler version of this, which is affordable, easy to transfer. And this, the Baby Saver Kit, we call it, and we've planned to make it at low cost. You can see this is Peter Watt, who I referred to earlier, and you can see some of our early designs that we went out to Uganda to discuss with. And in fact, when we took this one out, we said, look, here's our proud design. And they said, oh my goodness, you can never use that. It looks like a coffin. This is terrible. No, you must never do that. So we hastily had to change it so that it looked like an egg shape. And so here you go. Here's the egg-shaped Baby Saver. It's got the resuscitation platform, which you then, of course, you don't normally use, but you can just turn upside down and put it like that. And then in the container underneath, it's got resuscitation equipment, and you can see around here of very simple labels as to how to use it. It's easy to make. This is vacuum forming, where you get a piece of plastic and you put it over a mold like that, and then this table has got holes in it. It sucks it down and makes a shape like that. So, key points. Multidisciplinary collaboration, I think, is vital. I think this is a real example of a place where the midwives, the neonatologists, the obstetricians really need to work together to make it happen. If you don't get all groups tied into it, it probably won't happen. The baby responsibility transfers at birth, not at the cord clamping. I think it's very important that whoever's doing the resuscitation is the critical person. Don't leave it with somebody until the cord is clamped. Make sure you have patience at the time of the birth. Ensure your hemostasis. And I think that not only helps with maternal hemorrhage. Remember, you mustn't do manual removals, but it allows you to wait for signs of placental separation and reduces your hemorrhage rates. Bedside resuscitation provides great benefits, but it does take perseverance and it takes persistence, and you need to have everybody involved. And I suspect our greatest benefit of bedside resuscitation will be in low-income settings. So let me finish on that and take any questions. Thank you.
Thank you. Thank you very much, Andrew. Ola, do you want to take it from here? Shall I do it?
Yeah. Yeah, thank you. Thank you, Professor Weeks. This was a fascinating lecture. I really enjoyed it. And I think the historical aspect of this was quite new to me. So this was really great. We have received a number of questions in the Q&A box. But I think that Ola Andersson, are you there? Maybe we shall ask Ola if he has some comments to start with. And
I'm
then
here.
hi Ola.
Hello,
Would you
Ola.
like to give a comment?
Hi.
Well, thank you, Andrew, for an excellent talk. It's always interesting to have the obstetrician's perspective. And I was waiting for you because when we are talking about cesareans and delayed cord clamping, there is always two questions. And the one is the postpartum hemorrhage or the maternal blood loss, which you addressed a little bit difficult for me. You talked about some forecaps so perhaps you could explain that a little bit more for us that are not obstetricians, what precautions you do. And then the other question I have is regarding the blood gases. I know quite a lot of your colleagues in Sweden, the obstetricians, they perform the umbilical cord blood gas sampling before cord clamping while waiting. Have you any experience of that?
So two things. I think in terms of blood loss, the first thing I would say is be patient for the third stage, and that's both at vaginal birth and at cesarean section. Don't start putting your hand into the uterus to scoop it out. Wait, and the vast majority will come out on its own. But the question is, and I think our PPH rates have gone down at cesarean section as a result of delayed cord clamping, which seems strange, but it's because it's made us have to be patient. But there are these vessels, and those of you who haven't done a cesarean section, you'll see often as you cut into the uterus, there's large sinuses which run across. And often this is of course why you get the small nicks sometimes of the baby as you're going in with the knife, is that when that area fills with blood, suddenly you can't see what you're doing and you're cutting into a place where you actually can't see when you're getting down to the membranes. And it's very easy then to just make a small nick on the baby. So my tips, I guess, for doing that is if you see large sinuses, I think everyone does this anyway, try and avoid them because you can always move lateral to them. And once you move lateral and you get down to the membranes and then you just use your two fingers to open up, actually you push those sinuses to one side and you can open up, and often they don't bleed at all. Now, I think that's standard practice for most of us, so you can avoid often those sinuses bleeding. But also as you're cutting down into the uterus, use your finger. We always talk about cut and wipe and cut. So you wipe across the bit you've cut and then cut. And just by wiping, you get a blanching of that area just underneath and allows you to see when you get down to the membranes, because then ideally you can open up the membranes. Open up the uterus just external to the membranes, then cut the membranes, and the baby comes out. Now, of course, you may then still have big sinuses, and as soon as the baby's out, you can put, they're called green armitage. They're quite sort of flat, atraumatic forceps, and we have 5 of them on all of our trays, and you can just place them around the edges. Any of the bleeding points, you can put them on. So I normally put 1 on each angle and then up to 3 on any bleeding points. And then you're sat. Then you can sit and enjoy yourself. Maybe I'm a little bit sentimental, but I usually talk to the mother, and I often stroke the baby's foot at that point and say, "Come on, then, little one. Well, these niceties are always good for." Good for public relations, and the mother likes it. It makes a nice atmosphere in theatre. And in fact, we've done the same sometimes with the Life Start trolley, is that actually the mother, of course, can then touch the baby. So at the time of cesarean section or at normal birth, we sometimes had very premature babies being delivered, and there is a very nice video which actually we don't have the permission of the mother to share, but of one of the mothers putting her hand out and stroking the baby's foot whilst it's in the middle of resuscitation. And she spoke after of that being a transformative moment. It was really the only time she got a chance to touch her baby before it was whisked off to the neonatal unit. And it was just that person-to-person contact.
Okay, thank you so much. I
sorry.
think we have to move on because we have a number of questions from the audience, and so I'll ask you to try to give a very brief answers. And Ola, you can comment on any time you want to. So the two first question is from Bharat Vakaria. The first is, why the 2-minute delay? I guess he means why not 1 minute, or why not 3 minutes? And the second from the same person is, how do you manage the babies born by C-section under GA? I guess with low gestational age, I guess. And most so
general
in multiple
anaesthetic,
births.
I guess.
Yeah.
Maybe general anaesthetic, because that is a question that comes up. We manage them exactly the same, and sometimes you do get babies who are flat. You know, they don't have good respiratory effort, their muscular tone isn't great, but we know it's quickly reversible. We know it's not a harmful effect. The reason why we worry about babies like that is because they've got some kind of brain damage and hypoxia. And of course, that's not the cause. That's the general anaesthetic. That's the anaesthetic agent. Now, we actually have few women born by who give birth by general anaesthetic. But if so, we treat it exactly as normal. And then we have the pediatricians there on standby. And if the baby needs additional respiratory support, then that's fine, because it's reversible. It's a transient problem. Why 2 minutes? Actually, it turns out that 2 minutes was right. It was a guess when we first started. We knew that from Lelia Dooley's work that babies were very different in how much blood they transferred across in any particular time. The NICE guidelines had said 1 minute. Why 1 minute? Why not 3 minutes? Why? There wasn't really any good reason. We knew that the majority of the blood went across in the first minute, and then typically 85% would go across in the first minute, then another 10% in the second minute. Now, ideally, you just want to leave it as long as possible. Why are we throwing this vital oxygenated hemoglobin and stem cells into the bin? Who knows? So you want as much as possible across. And if the baby ends up with too much blood, well, drain it off at a later stage, but nobody does. So to me, we chose 2 minutes because we thought that 3 minutes probably wouldn't be acceptable to the staff, is the truth of it. Now, as it happens, the Lancet review that I was talking about earlier on has now separated it out into the benefits at 1, 2, or 3 minutes. And it looks actually as if you need to give at least 2 minutes. So that'll maybe be covered in the next webinar tomorrow or on Thursday. But it looks as if 2 minutes is critical, actually.
Okay, yeah, thank you. Diego.
Right, well, yeah, there are a couple of questions that maybe I can summarize. There's some issues regarding the possible effects of oxytocin. I thought it was interesting, Andrew. You told us that the clot clamping is because of back in the 60s that people are afraid of the effects. But are there any effects? I mean, there was the question of tachycardia. I think there's some evidence on the effect of oxytocin on the incidence of attention deficit disorder. Any comments on that? Any risks with the oxytocin being given?
Well, interestingly, my research has actually been the reverse way. So my very first work in this was in retained placentas. And then you've got a placenta which is still stuck inside with the cord hanging out. The baby's long gone. And what we were trying to do was inject oxytocin into the cord so it goes up into the placenta to cause a uterine contraction to expel the placenta. So we were looking at it sort of from the other direction. And actually, the transfer of oxytocin does transfer across the placenta, but very small amounts and very slowly. So to pick up any, you need to be looking at 10 minutes before you can detect any oxytocin being transferred across the placenta. So the amount passing across it is minimal, and which is good for the baby's point of view. It wasn't good for delivering of retained placentas because it meant that retained placenta injection, umbilical oxytocin didn't work. But I think so one concern is that it goes across the baby, and really within the 2 minutes or 1 minute that you're waiting, none gets across in that time. The second,
may I add something there? I'm a little bit unsure, but I think I found a paper about that the oxytocin levels in the newborn, at least the term newborn, it's 3 times the level of the mother's oxytocin level. So the baby has its endogenous oxytocin production, which rises during pregnancy, and at least at term, it's quite high by itself.
And there's been a
with
few
the preterms.
There's been a few sad cases where babies, newborns, have been injected with oxytocin by mistake, thinking that it was vitamin K. And those babies have been followed very carefully and with no adverse effects found. Doesn't mean we should do it, but it's reassuring that when it has been a bad accident, then it's not.
Well, we had such a case in Norway, and the baby got a severe damage. So we tested out. I had a newborn piglet model, so I tested out. We injected oxytocin in newborn piglets, and there was a tremendous rise in cerebral blood flow. It peaked up immediately.
Right.
So I'll be very, very careful with that.
Yeah. Thank you.
Well, I'm not quite sure how much time we have left, but maybe I can summarize one further question. I don't know. It's up to you when we finish. There's questions around what technology had to be in these bedside resuscitation trays. And of course, something that worries us as obstetricians is that we know that most of the expense on the trays is usually imputed to the obstetrics department. And obviously, we're not as knowledgeable as perhaps we should be in the technology. There's some questions regarding the need to monitor the temperature. And if I can ask just a general question, Andrews, do you think, I mean, there's justification for the enormous investment that some of these bedside resuscitation trolleys require? Can we go for a not so expensive solution?
Well, I think you probably can do. I mean, I'd be interested to hear what neonatal resuscitation isn't my primary. I'm very quick to transfer across to the neonatologies on these questions, but it seems to me that you don't necessarily need all this kit. You're only talking a minute, maybe 2 minutes. And certainly in Uganda, we've been looking at just a plain board or a tray, just a flat surface, because that's really all. If you've got something to keep the baby warm, a covering, something you can stimulate it with, and a flat surface, actually that deals with the vast majority of babies. There's very few babies, say, even at Liverpool with all our kit. How often do we do cardiac massage on a baby? Hardly ever. You know, this very rarely occurs, and certainly in low resource settings, that it's never. You know, if you get to that stage, then the outcomes are so poor that you shouldn't be chasing them. So I think in the UK we probably could simplify the kit quite a lot. Ola, what do you think? Do you think
I will address this on Thursday, but I think what you said now quite good summarize my talk on Thursday. But
oh, sorry, I've
no.
stolen your thunder.
No. It's really I think that I want to share the evidence, what we really have, what kind of evidence for different equipment on Thursday, and I also think it's possible to do it in a more simple way.
I think we have to start the closing now, and I think it's been a fabulous session. I hope, Professor Weeks, that you could look into the Q&A and maybe answer as many as possible online, so that we get everybody gets an answer. There are totally 35 questions, which is a lot. So I would like to thank all the participants for asking questions and for joining us. And I want to remind you about tomorrow. We have a new webinar. The speaker is UENPS, one of the leading researchers in this field. He's from California, cord management for the term and preterm newborn, same time. And on Thursday, Ola Andersson from Sweden will talk about stabilization and resuscitation with intact cord circulation, research and experiences. So please be back. And Professor Moretti, do you have some closing words?
And I underlined that it has been a really fantastic topic, lecture, really, really. So we couldn't start again better than in this way. I'm really happy about this. And so it's very interesting module. I think that the 3 lessons are so interesting for everybody. I am very happy that we started with an obstetrics topic. This is something new in our webinars. And so thank you for your collaboration. Thank you very much.
Well, thank you for the offer. Yeah, been a pleasure to be here.
Thank you.
Bye.
Bye.